Welcome to the Oxygen Alliance YouTube channel, where we bring you videos on installation, maintenance, and various trainings on oxygen equipment and devices. If you have comments and or questions, drop them in the comment section below or write to us info@oxygenalliance.org. Remember to like our videos, subscribe to our channel, and hit the notification bell.
Hello everyone, thank you for joining us today, and let me welcome you to our today's webinar brought to you by the Oxygen Alliance. My name is Victor Nzende, a biomedical engineer with the Oxygen Alliance, and I am excited to be your host today. I am joining this call from Lilongwe, Malawi, and I would like to know where each one of you is joining us from by just typing your name and location in the chat. For today's webinar, we'll be talking on the topic hospital-based medicine implementation in low and middle income countries. And our presenter today is Mr. Jala from Ethiopia. In a moment, I will just let him introduce himself. And I also would like to encourage you that if you have any questions along the way, please be free to type them in the chat. And if you need more clarification, you also be given time to unmute yourself, giving your comments, ask for clarity, and any questions that you may have. Yeah, so without wasting much of your time right now, I'll hand you over to our presenter today, Mr. Jara. You can just briefly introduce yourself, and then you'll go forward with the presentation. Thank you.
Okay, thank you, Mr. Victor, and welcome everybody for today's seminar. We are going to talk today about hospital-based telemedicine implementation in low and medium income countries. As you have heard, my name is Jala Dabala from Glando Biomedical Solution. I am medical device service coordinator here. So what we are going to see today is, first, we are going to define telemedicine, and then we will be highlighting the telemedicine contribution in building resilient health systems, most importantly in low and medium income countries. We are going to outline the technical infrastructures and equipment requirement for sustainable telemedicine in low and medium income countries. We are going to highlight the critical role of biomedical engineers in such a process. So lastly, we are going to discuss how biomedical engineers cooperate across the entire life cycle of telemedicine, starting from planning and implementation. So firstly, let's define the telemedicine. As all of you know, telemedicine is the use of technology to provide clinical services, clearing difficulties between healthcare professionals and clearing difficulties between healthcare facilities. When telemedicine is conducted, these services are to be enabled. First, we can see about remote diagnostics. When we say remote diagnostics, we are talking about teleradiology, tele-ECG, telepathology, and the likes. And another service that can be enabled by telemedicine is a specialist consultation. It can be real-time video conferencing or calling to achieve teledermatology, telepsychiatry in every clinical consultations and services through telemedicine. It can be achieved when laboratory technicians and radiology technicians and even cardiology nurses can, when they need consultation from specialists or subspecialists, or even when the specialists need consultation from subspecialists, telemedicine answers these questions. Not only these, not only between the professionals, but between the health care facilities, which means rural health care centers can get the support of specialists in the tertiary healthcare centers specialists. They can use their support to diagnose and even treat the patient, being apart from the availability of specialists or any needed physicians. Another service that can be enabled through telemedicine is patient monitoring. We can monitor our patients centrally through hospitals or wards, or even through between health centers, which are separated geographically. And this can be achieved when ward nurses, anesthetic nurses, ICU nurses, and even doctors need specialists from other ward or even from other facilities which are far from their facilities. They can communicate about the sign, the vital signs on the monitor. They can talk about how to repair the failure of any organ which is being displayed on the monitor, and they can get any consultation. This can be achieved in the hospital or even out of the hospital. I mean, some professionals can get their support from any professionals from other clinical afar from their availability, from their residence. This can be even achieved when the patient is at home, which can be monitored through the phone. They can send their vital signs, current situation to their doctors whenever he is, when only the telemedicine system is conducted. So let's see telemedicine contribution in building resilient health systems. It can bridge the gap that can be geographic, and that can be shortage of specialists, which we see from many low income and medium income countries like of our country, Ethiopia. Can improve access to specialists, access to consultation that can be provided from a specialist which is available in every time in urban area, while the need arises in the rural area. So it is cost effective, which means it can reduce the patient travel, and even here the caregivers travel and their cost, their time. We can achieve care from specialty centers to rural areas, and the system can be resilient. It can enable continuity of care during crisis, pandemics, natural disasters. As you can understand today, Ethiopia is facing this crisis of pandemic, on which we are helping now at Jinka Hospital. It is Marburg virus disease is outbreak now. In biomedical context, this is not just IT works. I mean, it may be conceived like that. Telemedicine is just not IT works. It is integration of medical devices, it is integration of data, integration of clinical workflow, which we need to work with from the startup. So when we talk about telemedicine, we have to consider about core devices and infrastructures that we can consider as a hardware backbone. First, let's see the first core device as a clinical device acquisition hardware, data acquisition hardware. At bedside, at the patient side, these devices can generate clinical data needed for remote guidance or needed for remote consultation of monitoring. These machines can be patient monitoring machines, they can be diagnostic devices, and they can be imaging modalities. Another core device is communicating and the telecommunication hardware. They will enable synchronous and asynchronous communication between providers of clinical services. This can be laptop, it can be desktop or tablets, or they can be phones that we use. And sometimes we may need audiovisual equipment like camera or microphones to conduct conferencing or online conferencing or calling to get clinical specialist consultations. And another core device will be networking and the connectivity hardware. These are networking switch we can see of routers, Wi-Fi connect access points, internet cabling systems, and another is connectivity equipment. It may be 4G or 5G routers, satellite terminals sometimes. Another device that we can consider is power supply and backup systems. is as critical for facilities with unstable electricity. This problem is common in low and medium income countries. We can think of UPS systems, solar systems, generator sets, and even hybrid of these facilities with surge protector and voltage regulators. Another core device that we have to think of is data storage system and software hardware. This can be local server or network attached storage centers, or even it can be hybrid of these both systems. Another core device we think of, we have to consider when we think of telemedicine is clinical collaboration and command centers hardware. These hardware can be in workstations, and it can be our phones to command and to help the collaboration of the system. Another thing we can think of is mobile telemedicine cards. This can be a Wi-Fi connected workstations when we use telemedicine system through our hostel. And another can be environmental support hardwares. These are when we install our server, they may need air conditioner systems and local cabinets, cable management systems. And these are core hardwares we need when we think of telemedicine implementation. So saying this much, let us see our responsibilities as a biomedical engineer in the life cycle of telemedicine system. Here, biomedical engineers' role. We are enabler of the system. We select the right device, the right tool, preparing the correct specification, and we help in the technology collection. And we are also integrator of the system. We integrate the system by making devices talk to each other and talk to the hospital systems if they are available. We even maintain the system, the whole system. We have to ensure the system is always safe, always functional, always accurate, and available for clinical professionals to use. So, knowing these are our responsibilities, from the start of the system, I mean from the planning of the system, biomedical engineers have to collaborate with clinicians to define needs before preparing the specification and before selecting the appropriate technology. As a biomedical engineers, we have to conduct site assessments for maybe power, network, and workflow system. On the stage 2, we have to install, configure, and calibrate hardware and software after purchase of the system. We have to lead acceptance testing, and we have to train the clinical staff, so we have to collaborate with them. And in the maintenance support, our role is still focused role. We have to create preventive maintenance schedules for us and for the user. And we have to manage warranties in the implementation of telemedicine. We have to manage service contracts, and we have to manage spare parts. On the fourth stage, we have to work on improvement and advocacy of the system. We have to analyze the system usage data for improvement for the future, and we have to advocate for the budgeting of the system so that the system is sustained. So saying so, when we come to reality check, which means when the implementation of telemedicine is achieved, these problems, as an example, can be arised, which biomedical engineers can solve. Let's use these examples for three problems as an example, and that we can solve. First, devices that are in the hospital cannot. Sometimes they may be interoperable. They cannot be interoperable. Sometimes they can create data storage problem, or they can create data feed problem. This problem can be solved at the planning process. When we prepare specification, we have to consider integrability with always when we provide the specification for imaging system, and integrability with health level 7 system when we even prepare specification for electronic medical record system or even patient monitoring devices. Their compatibility must be considered when we prepare specification. We select technology for our telemedicine system. Another problem that can be happen is when the managers set and forget the system, which means they will purchase and we will install and configure, but there is no plan for maintenance or ongoing development. So biomedical engineers must develop a development plan for the telemedicine system to continue. They may develop a 5-year or more total cost of ownership model for leadership. So this fallacy can be this problem can be solved by developing such a short-term and long-term plan for the budget of the machine, considering their maintenance, their spare parts, their training, and such like. Another problem that can be arised for the sustainability of telemedicine conduction is skill gap. This skill gap can be the engineer's skill gap or user's skill gap. So biomedical engineers being with IT professional or getting a certificate in IT system we have to develop our capacity in using and managing and in maintaining even in training the usage of and the continuity of telemedicine system. And even we have to train the users of the system in order to in order for the telemedicine system be continuous or sustainable. Before finishing this presentation, let me share some experience when we were installing one type of telemedicine, which is central monitoring. We have installed central monitoring system in 2 facilities in Ethiopia, Bethesda American Plaza and Zewditu Memorial Hospital, and one in Hawassa City, Bushlu MNCH. This may give you some idea of telemedicine regarding patient monitoring system. We first set up server, getting the support from IT professional. After setting up the server, we prepared the switch for connection of our bedside patient monitors, and bedside and patient monitors are cabled by these such type of cable, networking cable. These cables connect these here, and this switch takes the connection of bedside monitors, and this switch is connected to the server. Through this, we can get information from server, which is information of patient monitors through server. And secondly, this is a hardware setup. And second, we set the software first through at the site of patient monitor, central monitoring. This is central monitoring setup. Central monitoring setup, we set the IP address, gateway, ports. And this is when we set the network setup from patient side monitors. Patient side monitors, on the patient side monitors, we set the network setup, the selection of central monitoring system and ports and IP address. As you can see here on the patient side, these are what we can set when we see the network setup and selection of a central monitoring system. Sometimes we may install more than one central monitoring system, because in case of MinRay, one central monitoring system can only handle 64 medical devices, 64 different types of medical devices, in our case, patient monitor. So we have to select from central monitors we have installed already, and we have to configure IP addresses so that we can get information from server. So we have to also set up the gateway which we have already set on the central monitoring system. So finally, what we can see from central monitoring system is, as you can see here on the on above, there are idle beds, which I mean their monitors are idle because there is no patient there. And, in the lower, you can see the busy beds, which I mean that there are patients and the nurses are using their patient monitors, and those monitors, both monitors, they are all connected that we can see from central monitoring system. We can see whether they are busy or idle, and we can configure being from our central monitors. We can set up our alarm. We can set up whether we can see them or not see them. We can set up what physiological parameter we need to see on the monitor. Even we can close the patient monitors being on ours. So this is what we can see central patient monitoring system as a telemedicine in the hospital. So saying this all, let's summarize our today's webinar. We have seen that biomedical engineers are the systems architects. Our role is in strategic, not just. We are not only called for maintenance. We have to do our job from startup. We have to plan. We have to do technology selection. We have to do specification for the system to run smoothly. We have to engineer the sustainability of the system. We cannot hope for. So we have to carefully select the device. We have to develop the capability of the users and the technical persons, and we have to advocate for the life cycle budgeting as a biomedical engineer. This is our responsibility, and doing so, we have to collaborate with key professionals like clinicians. We have to collaborate with IT professionals, and we have to collaborate with hospital. So we have to advocate our values also. We have to use the data and project this leadership to demonstrate the way BME involvement can get its crucial focus in the system sustainability. So I have finished today's seminar from my side. So I am giving the table to you audiences so that we can get questions and discuss on the answers. Thank you. Let's continue building resilient health systems together. And I will be giving the chance to you. Thank you.
All right. Thank you so much, Mr. Kara, for that wonderful presentation. It was a very insightful presentation, and I hope our audience has learned much from you, especially from your practical experience that you have shared. Right now, I will invite comments and questions from the audience and speak.
Okay, thank you, Chala, for your nice presentation. Okay, thank you. I would like you for your introduction. Okay. For giving us overall introduction on telemedicine, and also you try to highlight how we can select our device, including when we plan to purchase one medical equipment, like including the compatibility with telemedicine, including spec preparation, and we also mentioned capacity building, which is good. The collaboration with other professions. So, thank you for your presentation. I want to say once again. Then my question is, what's the objective of this webinar? Then have you performed a need assessment in Ethiopia as Ethiopia and as African, or do you have any experience on this topic, and what the others African countries are exercising or performing this telemedicine? What the scope of?
Yeah, I think your question is about the objective of this webinar, and if there is a need assessment throughout Ethiopia or Africa, and if there is any experience from other countries. And another question is not heard because I was not hearing. You have another question, right?
Yeah.
Apart what I
Any
have said.
government or private hospitals, those can be pioneer, like for us. Yeah, any
That
government
can take
or
us,
private
yes.
hospitals you can mention as
Yeah.
exemplary.
Okay.
Thank you.
Okay. Talking about, thank you. Talking about the objective of this webinar, it is about giving an awareness on the need of since the need is available now, because we are seeing everybody is holding his phones today, which he can use for delivery of health clinical services, but we are not using it. Today we can use our phone to consult, to send clinical data. So telemedicine is not something very complex. It can be used everywhere. There is technology of internet, using internet everywhere. When we can use our phones to collect data of and we can send, we can receive clinical data. For this to be achieved, we have to have for example, imaging modalities, patient monitors that can send data through hospital systems. And hospital systems are today digital, and many hospitals are using electronic health, electronic medical record system through their wards, and these systems can be connected. This system can be connected through wards, not only wards. We can connect our hospitals through such systems by using connectivity. Maybe we can use IT professional to connect them. As you know, many hospitals are using PACS system, which means their machines are DICOM compatible. These machines may be hard to achieve, but maybe we can provide portable ultrasounds in portable or mobile X-rays to rural areas where there is no cardiologist to interpret the images, but we can get the image from rural areas and send it to where the radiologists that can give the clear explanation of the diagnosis from imaging. And today we can use our phone to do that. Possibility of using is available here in Ethiopia and any other low and medium income countries. So the need is available. So we, as a biomedical engineers, have to know the availability of the need, and we have to act on the availability of telemedicine system. Telemedicine system, it can be calling on phone, it can be texting, it can be teleconferencing through our phones, through laptops, through tablets. So it's a service that we can provide today. And there are some hospitals which are using this system. As I have mentioned in my presentation earlier, central monitoring system is one part of, or one example of, telemedicine. We have some hospitals to mention. It's according to my experience, but there may be other hospitals, maybe private hospitals that I haven't seen. But these three hospitals are hospitals that I have installed central monitoring system for them. One is Bethesda American Plaza. It is new in Hamlet, Magananya, and the other is Zaudi Memorial Hospital. They are using it now. And the other is Bushlo MNCH at Hawass Hospital, and they are using it now. This is not only the telemedicine system, but there are hospitals that are using PAC system out of their to get consultation out of their presence. This can be achievable, I think. But this webinar is just to develop our awareness, and that our roles are there and to act on. So the need assessment, the need is already, as I have talked, it's available in Africa, available in here, and it's possible to do. As you are seeing today here in Ethiopia, in the hospital, there is outbreak, but we are losing lives of patients because of lack of medical equipments, lack of specialists around. It is what we are doing now. We are providing medical equipment. We are installing it after the outbreak. So we are not being able to control it in time. Think of it that if the hospital were capable of providing services what we are going to provide in the future, patients will have a chance to have their lives with us. So telemedicine can have a solution for such problem. This problem is a pandemic, and there may be a natural disaster in the future. So we have to be ready, and in this system we are point of solution, I think. This is all I have for you, Bashar. Any other question?
All right. Thank you so much, Mr. Jara, for those answers.
Hello. First of all, let me say thank you, Oxygen Alliance and the presenter of tonight's session. I'm Job from Uganda. I would love to say, yeah, you've presented something so nice, well summarized, straight to the point. However, the presentations are clear, but as you know, in engineering, you can't speak and end at the theory part of it, because basically what we are on is a theoretical part of it. My question is, how can we tap this knowledge practically, other than ending at these sessions of online and then there's no practical backup? Because I'm sure not only in my country, but most African countries or as developing countries, we still have challenges to do with technology. We can talk this, but when it comes to implementation, it's the opposite. So how shall we tap this knowledge practically? Thank you.
Thank you. If I've got your question, you are asking about practicality of this system, I think, right? How can we implement practically, right, Job?
Oh yeah.
It is very good if we continue realizing this system in reality. I think as we have seen, we can provide hardware system for this system, and we can provide software system for this system sustainable. Practically, there may be hospitals that are using the system already, and if there is no, we can provide needed hardware systems and software systems, and we can provide knowledge to integrate them. We can start any hospital to use these systems. I think it is pretty practically simple to achieve, because as I have said earlier, telemedicine is not it's not about complex. It's about transferring data. It's about sending data and receiving data. For this to be achieved, our devices must have to be compatible with already available standards like DICOM standard, as you know, HL7. It's about capability of devices to talk to each other and to talk to available systems of hospitals, be it LIS, laboratory information systems. It's available everywhere. Radiology information system is available everywhere. I mean, every radiologist, they record patient demographics, they will record age and everything like that. And their devices record the image when they go to get their diagnostic system. And our computers are saving this data also. So telemedicine is about sending these data and receiving such data, and it's about reading these data, retrieving from our phone or from our laptops or tablets where we are. And when these systems are connected, our physicians can interpret the diagnostic modalities sent to them. They are, and our nurses can get consultation from any other doctors about their monitoring systems, about their patients' vital signs which are being observed on the tele. So I think it is it can be very simple, and it is very simple to start whenever we are starting from simple to complex. It can be achieved, and I think we can start with central monitoring systems, and we can start with parks, and even we can start with providing a reminder for a schedule of operation schedule, or even for drug timing, drug scheduling schedule. Ethiopia, we are using medical equipment information system for management of maintenance of medical equipment, and the system can send the SMS when there is. So it is such simple. We can send SMS when there is a schedule of operation or a schedule of consultation from the doctor for the patient, and we can do something like that, and it is considered a telemedicine, serving from afar, serving a patient, being in a rural area, getting a clinical service, being in a rural area from urban area.
Engineer Victor.
Yes,
Hello.
I can hear you.
Maybe I did not frame my question so well, but what I meant is, can this, because I'm looking at, is this Oxygen Alliance or Gilando Biomedical Solutions have practical sessions of this, whereby the team or the teams meet?
All right, great. Thank you so much for that question. One thing that I would say is that as practicing biomedical engineers, technicians from the school, I think practical sessions really are very valuable. So the way I would view this webinar is that this is actually a starting point, that at least we understand how these systems are, the importance of systems, the critical roles. So right now, I would say that from us, first of all, is to provide this webinar. I cannot say for now that we are going to be doing practical sessions, but rather we view this as a starting point to make sure that the biomedical engineers are aware, and at least they have the mindset that these things are achievable. So maybe in near future, it's something that a practical session could also be considered as well. But yeah, I would like to say that yes, practical sessions are well, and I think I even see a potential training on this as well. For example, the patient monitors, as Mr. Chara said, that they have, like, you can actually connect them. So it's rather important that at least we also know practically how these things are done. Yeah. Thank you. Over to you, Victor.
All right. Thank you so much. Job, I don't know if you had your questions, if you had your question addressed. That was George Kaibe with the Veterinary Digital Alliance. So I think was in the best position to address your question. So I don't know if that answers your question. If not, I think you can come in again. I'll give you the chance. For now, I can see a hand from Janet Douglas. So I also give the chance to Janet to unmute and speak.
All right, I just wanted to add what Lloyd said. Normally, if you have been attending Doxin Alliance webinars, you notice that the audience are across the continent. We do have people from different regions, different countries. And so we're talking of the practical side of things. It means we also have to consider people from different regions. Because if we're doing a practical session, let's say in Malawi, we should also think of the people who are based in Tanzania, the people who are based in Ethiopia and the other countries. Another thing is we understand that people really need that, but I think with the resources that we have, this was like a stepping stone to at least give the platform to people to be aware of how to go about things as engineers out there. And because we're still developing and finding ways how we can advocate for maintenance, repair, and also innovation in the biomedical engineering sector, that's why we had to go ahead and think of coming up with the BME Conta app so that we can all connect and at least give each other different analogies and experiences in the world of biomedical engineering. On top of that, if you have ever had a chance to check the Oxin Alliance YouTube channel, you'll see in as much as we talk about these webinars, we also get an opportunity to do maintenance or tell engineers how to maintain other medical equipment that we found resourceful or the ones that are really available to the biomedical engineering team for the Oxygen Alliance. So if you check the YouTube channel, you'll find that there are a couple of equipment that we have done videos on, different brands of oxygen concentrators. We have done tear downs for suction machines, nebulizers, so that we still have that platform to say, let's see how this thing is done. But however, I would like to recommend for pointing it out, but as Oxygen Alliance, I would say we are trying our best to make sure that all the engineers across the continent are helped and have at least the required resources to work in their respective areas. Thank you.
All right.
Thank you,
Thank you so much, Janet, for those insights. Reaching this extent, I want to extend my gratitude to you, Mr. Jara, for showing up today and delivering this presentation to our audience. I hope it was insightful and we had the chance to learn a few things from you. Yeah, so right now there will be a form that will be posted in the chat. It's a survey on our webinars this year. So I would like to ask your audience to please spare some of your time and also fill out the form so that we have your feedback. And I also would like to unofficially inform our audience that this was our last webinar for this calendar year. So there will be an official communication, but unofficially I would like to inform you that. Otherwise, Mr. Jara, I don't know if you have anything else that you would like to say. If you do, please, this is your time. You can say anything that you have. Over to you. If you have anything to say.
Okay. Thank you for everyone. But let me say something on the concern of Bashatu and Job, I think, right? Regarding the practicality of the telemedicine, I am sure that it is simple and any hospital can start using it. And even I think many hospitals are using it already. As a biomedical engineer staff, we are ready to help in the actualization of the system. We are ready to help Oxygen Alliance to make this happen. Maybe in the future, just like they provide the video of tearing down the equipments, we can. I think we can have a session to have a video of or training on practically doing the system setup. And if there is no other question, my presentation ends here. And I thank you all of you. We can talk to each other from time to time in the process of making this happen real, using telemedicine real everywhere in Africa, because I think it's possible to provide needed hardware and software, and it is possible to provide any knowledge needed to configure this all. Thank you.
All right. Thank you so much for that, Mr. Tara. And we are really glad to have you. Yeah. So reaching this point, I think we can end the call, and I would like to extend my gratitude to our audience as well for joining us. And just to remind you, there's a form in the chat. We would really like to get your honest feedback on our webinars this year. Please fill out the form before leaving. And also, if you have any further queries, you can always reach out to us through our email, info@oxygenalliance.org. Otherwise, that is it for today. Thank you so much and have a good evening.